COVID-19 is a massive challenge for all of us engaged in the fight against HIV and AIDS. Not only are people living with HIV who are immunocompromised likely to be more vulnerable to COVID-19, not only are HIV prevention and treatment programs suffering significant disruption with frightening consequences for those on ART or those most vulnerable to infection. Not only are financial resources, medical staff and equipment, and political attention and visibility being diverted from the fight against HIV to combat the new virus. Not only are many of those amongst key populations especially vulnerable to the economic consequence of the pandemic itself and of lockdowns, but also in many places the somewhat technocratic, top-down public health measures being taken, threatening either inadvertently or actually being exploited to recreate human rights related barriers to access and to fuel stigma and discrimination. After many years of progress in the fight against HIV and AIDS, and in promoting a more rights-based, people-centered vision of health, we face the prospect of going backwards. You'll all have seen the UNAIDS WHO analysis that suggests that interruptions to ART could see an additional 534,000 deaths over the next 12 months. That would take us back to the annual death toll we saw in 2008, 12 years ago. It's staggering to think that we could lose so much, so fast. That many lives, all that effort, all those billions of dollars that got us this far. We cannot let this happen. That should be our red line. We cannot go backwards. In the fight against HIV and AIDS, every one of our gains are so hard won, and we cannot surrender them. We owe it to those who have died, to those who are infected, to those who are vulnerable, to prevent this happening and to continue our progress towards ending the epidemic. So, what should we do? First of all, we must act quickly to adapt HIV prevention and treatment programs to the new reality. The disruption on the ground is real. Results from our latest survey of over 100 countries in which we invest suggest 85% of our HIV programs are suffering some level of disruption, with about 15% reporting high or very high levels. On the other hand, we're seeing national AIDS programs and civil society organizations across the world innovating and changing with courage and creativity, shifting to multi-month dispensing and home delivery of ARTs, providing nutritional support and other forms of support to the most vulnerable, moving prevention activities online, accelerating the rollout of community-based and self-testing. We need to ensure these initiatives are supported, scaled up, sustained, that good ideas are disseminated quickly. Second, the HIV community should lean into the response to the COVID-19 crisis. Much of this response is actually based on the capabilities and infrastructure put in place to fight HIV anyway, whether it's viral load testing instruments being used for COVID-19 diagnosis, or HIV community outreach organizations supporting communications and contact tracing. We should ensure that all we have learned about how to fight one pandemic is used to fight this one. the imperative to let and empower communities to lead, the imperative of equitable access to medical tools, the imperative to reach out to the poorest and most marginalized. That's how we ensure the COVID-19 response becomes more people-centered, more rights-based, and more effective. That's how we ensure that in the fight against COVID-19, as in the fight against HIV, we leave no one behind. And make no mistake, we need the response to COVID-19 to be effective. Otherwise, it is the same people, those who are the most vulnerable to HIV, who will again be the ones who suffer most. Third, we need to ensure that the COVID-19 response strategies take full account of the knock-on impact of diseases such as HIV. That the measure of success is not just minimizing the deaths from COVID-19, but the total deaths caused by the pandemic, including the knock-on impact on HIV, TB, and malaria. In some of the countries in which the Global Fund invests, this knock-on impact could be as much as or exceed the direct impact. If the goal is simply to be minimizing COVID-19 deaths, we will see huge diversion of resources. If the goal is minimizing the total impact, we'll still see some diversion, but at least we can be thoughtful about how to manage the trade-offs and interdependencies. Fourth, we need to act to protect those in the front line. And I don't just mean salaried doctors and nurses. I mean all those providing vital services, including community health workers engaged with key populations. This means providing training and high-quality personal protective equipment, PPE. And finally, we must act to fix the most glaring weaknesses in systems of health. What these are differs from country to country, but laboratories in most countries are struggling to cope, and it's viral load testing and TB diagnosis that is getting squeezed out. Community-led systems are being encouraged and nurtured in some places, but ignored or resisted in others, and that won't work. If there's one lesson we've learned from the fight against HIV and AIDS, it's that you need community leadership. And that will hold true with COVID-19 as well. The Global Fund has moved swiftly to support countries in responding to COVID-19. At the beginning of March, we introduced grant flexibilities, allowing countries to use grant savings and to reprogram up to 5% of their allocation to adapt their HIV, TB, and malaria programs, to support their COVID-19 response, and to make urgent fixes to their health systems. That made up to $500 million available. In April, we went further, introducing the COVID-19 Response Mechanism, or C19RM, making another $500 million available. So far, 96 countries and 8 regional programs have accessed these mechanisms, investing over $369 million. To give you some examples of the actions that have been taken, in Kenya, BHESP, one of the oldest organizations providing support to sex workers, has been providing ARTs, condoms, hygiene kits to sex workers and supporting them. In Zimbabwe, Roots Africa has been providing nutritional support to the most vulnerable women and girls. In Ukraine, 100% Life is providing ARTs by courier to people living with HIV so as to minimize their exposure. In Uganda, there's been extra support provided to sustain prevention of mother-to-child transmission interventions and to adapt differentiated service delivery models. Across a number of countries, we have supported increases in HIV self-testing, increased supply of antiretrovirals to enable multi-month dispensing, and also a range of innovations to enable outreach, health education, training and consultations to be done digitally. But this is only the beginning. If we are to prevent COVID-19 overwhelming health systems in the most vulnerable countries in the world, and the potentially devastating impact that could result in on HIV, TB, and malaria, as well as on maternal health and immunization programs, we need a different scale of response. The Global Fund recently published a report on mitigating the impact of COVID-19 on countries affected by HIV, TB, and malaria. In this report, we estimated that countries need an incremental $28.5 billion over the next 12 months to do four things: adapt the HIV, TB, and malaria programs to avoid them being derailed, to protect vital frontline health workers with PPE, personal protective equipment, and training, including community health workers, to make urgent fixes to health systems, including laboratory networks, supply chains, and strengthening community-led systems for health, and to enable countries to access the tools they need to fight COVID-19 even before vaccines or therapeutics become available, most obviously by helping them massively scaling up testing, tracing, and isolation. The Global Fund is committed to playing our role in this response. As the institution created to fight the last pandemic affecting humanity, we bring a unique combination of capabilities to the fight, not least our understanding of the imperative of engaging and empowering communities. Moreover, no other institution is as well placed to manage the complex interdependencies between the response to COVID-19 and the knock-on consequences on the other diseases. We must leverage the infrastructure and capabilities put in place to fight HIV, TB, and malaria. But we must also not lose sight of the risks to these diseases as well. So when we use Abbott and Roche molecular diagnostic instruments that we have funded for HIV viral load testing, or GeneXpert instruments that we funded for TB diagnosis for COVID-19 testing, we mustn't forget the imperative of continuing the viral load and TB testing. Saving people from COVID-19 only to have them die of HIV and AIDS or TB isn't success, or vice versa. So we must look at this not just as a fight against any one particular virus, be it COVID-19 or HIV, but as a fight against the infectious diseases that most affect and threaten the poorest and most marginalized. We must fight this new fight, and we must finish the unfinished fights against HIV, TB, and malaria. And we must get better prepared to fight pathogens as yet unseen. Above all, in the fight against HIV and in the fight against COVID-19, we must leave no one behind. Actually, my nightmare is a scenario where the rich parts of the world succeed in controlling and containing COVID-19, effectively eliminating it as a public health threat. But the virus still persists and still kills large numbers of people in the poorest countries and among marginalized communities. In other words, the fight against COVID-19 follows a path not dissimilar as what has happened with the earlier, still unfinished fights against HIV and TB, becoming in a sense a residual pandemic, no longer thought of as a global health security issue, a fight where we have, to put it bluntly, we have left people behind. But there's also a much better scenario, where this crisis, the COVID-19 crisis, becomes the catalyst to reframe and re-energize the fight against HIV, where the whole idea of residual pandemics becomes unacceptable, where we truly commit to leaving no one behind, whether to HIV, COVID-19, TB, or malaria. To get to this place, we have to demonstrate that this is all one and the same fight. That the battle against infectious disease is not just a battle against any one particular virus, but a commitment to make everyone safe. That it's about finishing the fights that we haven't yet won against HIV, TB, and malaria. That it's about winning the new fight against COVID-19. To get here, the HIV community needs to step up, to grapple with a new reality, to act. This is the community that will make the world's response to COVID-19 people-centered and rights-based. This is the community that will make the response a total response, not just narrowly focused on those testing positive to COVID-19. We need to show leadership. We need to unite to fight.